On this channel, we talk about radiation quite a bit, but radiation does have side effects. It has sexual side effects, it has urinary side effects. Well, for those men who may suffer urinary side effects, there is Prostox, which is an assay that'll help predict whether or not you will suffer from urinary side effects to a low or high degree. We've talked about Prostox quite a lot on this channel. You may have heard of MiraDX or MiraKind, but today we get to interview the co-founder of MiraDX and MiraKind and hear from her perspective how it was created, all the information that she put together. Her name is Dr. Joanne Wiedhaas. I've looked up to her for quite a bit because she's just somebody who really cares about patients. She's a radiation oncologist with UCLA who treats breast cancer, but she created this product in prostate, and it's just developed immensely, and it's also really great information for patients to know who are looking at radiation as an option. So without further ado, here's my interview with Dr. Wiedhaas. So thank you so much for being with us today. We are so excited. We talk about Prostox on this channel in so many different videos. We have been fans of this assay forever because it's so amazing that in modern day medicine, you're able to be so strategic. And I think that when patients deal with the side effects of something and now being able to even know what side effects they may or may not have and helping to have really detailed information particular to them so that they can make great decisions for their own care is really important. So, you know, you came up with this, you invented it. Dr. Michael Steinberg is the one that introduced us to you and was like, you know, hey, you need to know about this technology and these really cool things. So how did you even discover it? Can you talk about what the test is and kind of your background in it?
Sure. My background, I'm a radiation oncologist, but also a scientist and a molecular biologist. I would say that I was driven by a combination of what I saw during my residency at Sloan Kettering as really obvious pain points that baffled me a little bit, and I just knew that we needed to do better. And one of those was how differently people responded to treatment. So, you know, much of the world of oncology is focused on this is your tumor type, everyone gets this treatment. But both for response to that treatment and even side effects of that treatment, it so clearly just depended on the patient, not on their tumor. So that was a really obvious thing to me, and there was no way to predict it. You know, you'd have the nicest people or the healthiest seeming people, and they would just have very different responses. So that was a very obvious clinical need that I could see, which was very motivating. And then I was also just interested scientifically in, you know, what even in our normal DNA leads to developing a cancer. I have lots of healthy patients, something's different about them, but also is there something in there that's going to predict how they respond to treatment?
You know, we hear these words as patients or as advocates like KRAS and mutation, and it kind of sounds like a sci-fi movie. Like, were you in a lab and someone told you about it? Did you discover it yourself? How did that process happen?
I actually, as a medical student, became interested in RAS, which is one of the first discovered cancer genes, at a lecture about viruses and how originally viruses were thought to cause cancer, but it was actually that they'd infected cells and picked up a piece of normal DNA and took it with them, and that caused cancer. And I thought it was amazing that there are parts of our normal DNA, our genetic material, that if you didn't control them, they would cause cancer. And RAS was one of the first examples. It's called a proto-oncogene. So I was very interested. I ended up doing my PhD in the lab of that person, John Coffin, that gave that lecture. So I was very interested in that protein itself, RAS, and how tightly controlled it is. So, you know, all of our genetic material takes us from, you know, a fertilized embryo into a full-grown person, and then it's with us throughout our life. Trying to understand, obviously, when someone gets cancer, a cell has kind of lost its control signals. It's still part of you, but it is no longer being controlled by you, and that leads to a tumor. And there's an incredible amount of interest in why does that happen, right? How does that happen? Mutation of RAS actually is in 30% of cancer, so that is one explanation for that happens. But no one really understood what happened first. How did it get mutated? How did it change? There was a recent discovery of a new way DNA was controlled. The new control of DNA is through what they call microRNAs, small pieces of our DNA that never turn into a protein or a tool, but actually are really master controllers. And they weren't even discovered. The first human microRNA was found in 1999. And that sounds like a long time ago, but actually in the world of science, that's not a long time ago. DNA was discovered in the 50s, 1950s. These new regulatory RNAs, we'll call them, could maybe help explain some of the differences we'd see in how people responded to treatment and even who developed cancers. And when I moved to my first faculty position at Yale after residency, I listened to a talk from a colleague, Frank Slack, and he had discovered actually that first human microRNA. I will note that his boss just got the Nobel Prize this fall for the discovery of microRNAs. Gary Ruvkin, he was in his lab when Frank discovered this microRNA. But it turns out that the microRNA he discovered regulated RAS, which was a protein I was super interested in. So we started working together back in 2004. Working together, kind of bringing together, he's a developmental biologist, which is where microRNAs were discovered. I'm an oncologist, obviously. And he really wanted to apply them in cancer and wanted to understand what went first, between the microRNA and RAS, that how did people develop cancers? Was there some miscommunication? And through a project we had in about 2006, we discovered this first difference that people walk around with in how that regulatory RNA could control that really important proto-oncogene RAS. That's what we call the KRAS variant. It's not a KRAS mutation. It's just a difference that like 10% of the population has. And you live a good life and you might be fine, but there's a little bit of a miscommunication. So different stresses seem to allow, I'd envision kind of a vicious cycle happening and you could develop cancer. And so patients with that difference we found are at a higher risk of cancer, particularly women. And I understood pretty quickly when we were kind of looking at these patients that this could explain a lot. So not only who gets cancer, but it turns out these regulatory RNAs, microRNAs, we use them every day in managing how we respond to stress. And of course, cancer treatment's a huge stress. So it wasn't a big leap to think, wow, maybe differences like this could explain why people respond so differently to cancer treatment, either good or bad. I mean, they might have fantastic responses. They might have terrible responses. They might have no toxicity. They might have terrible toxicity. But they're things that you live with every day, and until you stress somebody and use those parts of your DNA, they wouldn't look any different, which is what our problem has been. We'll look at people, they look exactly the same. Their cancers look the same. They're the same age, they're the same gender, they're the same ethnicity, everything. But they can have opposite responses. And so, we really thought this could explain it, this class of regulatory differences in people.
Before I get to my next question, I just want to remind you that you can come hang out with us here at PCRI at the LAX Marriott on September 5th through the 7th, and we are going to be answering patient questions in person. We have an incredible lineup, and we would love to see you there. You can learn more at pcri.org. Also, if you would like to support us financially, you can do so at pcri.org/donate, and don't forget to click subscribe to this channel because we want to help you, and it is a great way for us to help you, so click that subscribe button. Now back to my conversation with Dr. Wiedhaas. There's so many different factors to pick on here and talk about, but the fact in 1999, this microRNA mutation, I mean, that's just 26 years ago.
Yeah.
And then 5 years later, you're building that KRAS and looking at that combination. So, I think it points out there's a couple of factors that I think it helps explain. Number one, I think a lot of times patients get very frustrated. It's like, well, my dad had prostate cancer, my friend has prostate cancer, my buddy had this treatment, my buddy had that treatment. And I love the explanation that you gave because I think it really shows why patients differ so often in treatment and how it really, you can't get the same treatment for the same age for the same person and it's going to have that same outcome.
Right.
And while that is incredibly frustrating, it is nice to know that these new technologies and these new combinations of assays and different things have begun to come about so that you can really have strategic medicine for these patients. And so when it comes to, looking at those variants, you mentioned that 10% of the population has this KRAS mutation.
Yes.
But this is only one factor in the prediction of cancer, correct?
Yes, absolutely. And while originally we did work kind of on the role these differences played in cancer risk, we have really moved also now to, okay, that is a complicated area, predicting cancer risk. What do you do with that information? That's just a very unclear path forward. We still do have some of those programs going on. But when I came to UCLA in 2014, I proposed that we could try to use these to understand and personalize radiation, an incredibly high technology area. I mean, it is like space age radiation. The machines, the delivery, it's really incredible. Brilliant minds for 100+ years have worked to target it and deliver it as safely as possibly. But we still have patients that are just radiosensitive. And since they've never had radiation, there's no way to know that until after they've been treated. So to know that ahead would be really meaningful. So I proposed that, and Dr. Steinberg was very open-minded, and UCLA was very supportive of new technologies to improve patient care. I mean, that's really what they're about, which is terrific. And I found wonderful colleagues there to help answer these questions. Prostate cancer was a cancer where it's very useful because, fortunately, prostate cancer patients can live a very long life with their diagnosis. So quality of life matters incredibly. If you know you're going to live for 20 years, you don't want to be reminded 20 times a day that you've been treated because you have a lot of symptoms. And UCLA does a lot of advanced technology, and they do this accelerated radiation where it can be done in 5 treatments. So it's a new area. They had a lot of patients. Amar Kishan is a wonderful collaborator, a wonderful clinical trialist. And he said, well, let's look at these in these cohorts. I have these groups that have gotten this accelerated treatment, and let's compare it to people that got a longer course of treatment and see if we can predict this. And I deferred to him. He said, late urinary toxicity is really problematic. That's a really important pain point. So that's how we started with the Prostox test.
That's incredible. I mean, it's so exciting to see how all of that came to be, because even when I started working in prostate cancer like 13 years ago, I mean, we didn't have any of this. It's wild. And I think a couple things, you mentioned, it's quality of life matters so much, but so many men, even today, there's a couple of known trends in prostate cancer, as you more than me well know. It's like, they are offered surgery versus radiation. Mm-hmm. A lot of people just want to get it out. It's understandable, but those long-term side effects, and 50%, well, it's probably more, but depending on the, being treated by that surgeon, what type of side effects they're going to have. And then there's the idea with radiation, because radiation was so toxic back in the day, that there's still that lingering kind of trend and rumors of like, oh, it's radiation, it's so intense. And yes. Unfortunately, a lot of men don't realize, and obviously you need to go to state-of-the-art facilities like UCLA, but the advancements that have been done in radiation are astronomical, and now that you would have something like Prostox to even talk about, the urinary side effects. So going into Prostox, how did it go from, okay, you developed it at UCLA, what were the clinical trials that started all this?
When I was at Yale with Frank Sack, we actually co-founded a company. It's called MiraDX in 2008. That really worked on developing a whole panel of genetic differences that people have that were like the first one we discovered. So we have a library of them that the company has worked for years to curate and figure out what would really matter and what could predict different responses. So Amar, he had run 2 clinical trials for SBRT and had colleagues in the prostate world who had clinical trials of standard fractionation. And the great thing about the testing we do is because it's in your DNA, in your genetic material, we can use samples from any source. So it can be a blood sample from any time during treatment. It doesn't change. It can be a cheek swab, and it's stable. It doesn't matter when you collect it, at the time of day, the time during treatment. So they did have blood. Prostate cancer patients often give blood for PSA and things, so they did have residual samples. So we were able to obtain those and run those on the platforms at MiraDX to test all these markers. Then with a lot of statistics, I have very wonderful, smart statistical bioinformatic colleagues. They were able to develop signatures from these differences predicting late toxicity to either treatment.
When it comes to Prostox then, I think that a lot of patients probably want to know, does it work in everybody? can any prostate cancer patient take it and get accurate reports?
So what Prostox predicts is the response to that specific treatment. It doesn't matter the delivery treatment. It's really about the size of the dose you get. So there's a difference between the SBRT, the 5-day big doses, or we call it conventional or moderate hypofrac, which is smaller doses over 5 to 7 weeks. That is what predicts the outcome. That's what the signatures predict. So they're really predicting a patient's response to that treatment. So ethnicity doesn't matter. If the target's the same, it will still be predictive, basically. It's about the patient's prediction, less so about exactly the way it's delivered.
And does it matter, localized versus metastatic, because it's based off the person's DNA? Those aren't factors?
They're not. So that's an interesting question that's come up. So if someone has limited metastatic disease, but they're still getting SBRT to the prostate, it will still predict urinary toxicity. It won't make a difference.
Okay. So you can have somebody with like oligometastatic disease and, lymph nodes, maybe a couple of bone mets, and it still works.
Absolutely.
That's really cool. Is it only in SBRT? Does it work in other forms of radiation?
We have a signature for SBRT. We also have a signature for the conventional fractionation.
Okay.
So we have 2 tests for prostate.
That's so cool.
The nice thing with that is that if you're high risk SBRT, so I will say, so when we test people that are coming for SBRT, about 15% will be predicted to be at high risk of toxicity. The great news is that for 90% of those patients, it's safe to get slower radiation.
Well, that's a great statistic to know, because I think a lot of patients are kind of wondering, like, well, if the toxicity of these things when it comes to urinary side effects, what if I get both? And I think that the fact that it's only 1% is good. So when it comes to these systems, as far as the timing of it, at what point would it be best to get this?
Anytime before you're making a decision for radiation. So the nice thing also with prostate cancer is that usually you have some time. It's not a sudden rush, oh, we need to treat you next week. Sometimes they'll be on, anti-hormones before treatment, so they might have a little time that way. They often are still deciding between which type of treatment to get, surgery versus radiation and what form of radiation. So any time along that course as a piece of information. As you mentioned, you can't find anyone in the world that isn't afraid of radiation. It has a terrible rap. I mean, of course, because it can do terrible things in the world, but it is incredibly high tech, but there are radiosensitive people. And the great news is we can figure out who you are actually before you have to make a decision. So you have a lot of flexibility.
I think when it comes to the radiation side effects, patients think about things like, okay, well, radiation by itself just sounds scary. A lot of patients have a hard time getting used to the idea that it is safe.
Right.
And we talk a lot about, radiation burns. You want to make sure that you're going to a great facility. You want to make sure you're using barrier gels if you can, if it's not a great facility especially, because you want to get that track record. But when it comes to urinary side effects, I don't think that patients understand it's not sometimes a temporary situation. It can be a permanent issue for the rest of your life that you're dealing with. And then a lot of times patients aren't told. And that's really hard, is when they are suffering. It's like, here you're dealing with travel, you're dealing with, just the impact of cancer, emotionally, anxiety, mentally, your work, then you're getting treatment for it, the financial cost, and then it comes into, now I'm stuck with these side effects forever.
Right.
And so it's something that I wouldn't wish on anybody, and it's so cool that we have now a technology that it could at least help alleviate part of that and give them that information. So
Absolutely.
When it comes to the process, okay, so I go in and I tell my doctor, maybe he's not talking about it. Like, how would you, like, as the person who founded this, what would be the best thing you can tell a patient to go in and talk to their doctor about Prostox?
Radiation oncologists are starting to hear about it. My heart is always with the patient as an oncologist. And, MiraDX offers Prostox. At this point, we started out with early access providers who are smart, brilliant clinical colleagues who treat a lot of prostate cancer patients. And we started, and we have about 20 places around the country where we work with them. There's, at this point, no cost to the patients for this. And the goal is to have them give feedback. How is it useful? Any test, I always want it to be useful for the patient, but you have to, the doctor needs to want it too. It has to be useful information. And then, someday insurance needs to understand that we're actually, besides just helping people, it actually saves the system money as well, which is great. However, we started this early access program through the physicians where we let them offer it to patients. We also, about a year ago, started allowing patients to access it because there were so many people interested because of increasing awareness, some through you guys, which is wonderful, that we started allowing people to access it by joining a study through the nonprofit MiraKind. So at this point, patients, ideally, your doctor will know about it or you can ask them about it and they'll inquire. But in the case where maybe you're still with your surgeon and you haven't quite gotten to a radiation oncologist, you can actually still access the test yourself by joining a study through MiraKind. There is a cost to that, but it's significantly discounted through the nonprofit so that you can get that information, because we do think that's important to know if radiation is a safe option for you, and it probably is because it is for 99% of people. And as we move forward and we're going through insurance, which will be happening over the next couple months, we will encourage patients to have us at least try to invite your doctor to order the test for you. But patient access is incredibly important. I never will have a test that patients can't get, that if it's a test that could help them, that is just completely counterintuitive to who I am as a person. So there is a path with, already a plan for very limited cost for any patient and important financial support as needed.
Dr. Scholes introduced you to me, and I learned about you. And I remember one day, he came into the office and he was so excited. And he goes, "You got to meet this Joanne Wiedhaas. I mean, she cares about patients, Alex. Do you realize how rare this is for doctors to put that much of an investment in patient care and putting patients first?" And it's been fantastic to see firsthand through you and through MiraKind, just working with you guys as partners, because it's been so cool to see that these patients are getting access and they're very grateful for it. I think the reporting is very understandable and the communication is really great. Can you actually talk about the reporting? Like, patient goes and gets this, assay. What does that reporting look like?
We also wanted to make it that it's very easy to understand and that patients could have access to their results in a digestible way. So we've worked really hard on that, on just creating a graphic where it's very simple. You're high risk or you're low risk. And high risk is obviously bad. You're at a significant, about an 80% chance of toxicity if you're high risk to the test. But for the majority of people, your risk is lower than what you would be quoted, which you should be told is about a 15 to 20% risk of toxicity. But if you're low risk, it's more about 5 to 10%. So it's not zero and it's not 100%, but it really separates people. Patients can request to have, if they're going through MiraKind, they request to have results shared with them. And then it is a simple, secure way we deliver it and report it as your low risk or high risk. And then they can download the report, which has a graphic that really shows the same thing. Through the clinics, we've been requested that the doctor can request that if someone's low risk, that is directly shared with them. Because UCLA, they were testing so many people and they'd call and it would be a 1-second conversation because the patient's like, great, low risk, got it, I'm moving forward with radiation. But it seems straightforward for a patient to understand and to be communicated. So we often, if someone's low risk, we're able to send that result directly to them as well. High risk patients, it is required that the physician discuss that with them just to make sure there's been good communication about that.
If somebody goes and they have their blood or their saliva, so there's no preference based off the company?
Yeah, we really always just get the cheek swab. Easier for patients. I hate having my blood drawn, but I know generally a lot of patients are willing to do it. So yeah, either way, if someone requests a test through MiraKind, they're mailed a buccal swab, it's just a cheek swab with return mailing. Often, even if a doctor orders it, they will just request that the swab is sent to the patient. So it's great. It's through 2-day UPS. A patient gets it with instructions. We have never had someone fail. People get very worried about it. They're like, I don't know if I swabbed enough or I drank water right before. I've never had a swab returned without DNA. So people shouldn't be so worried about it.
I appreciate that. I always got nervous during COVID tests because we would test ourselves before going in the office. And they're like, you need to swirl left and swirl right. You need to go for this many seconds on your left nostril. And I'm like, did we do it? So I totally get it, because it also kind of seems a little like you're putting a swab in your mouth and then all of a sudden you're just like, that really worked. That's going to give me all that information.
Amazing. It's amazing. But there's DNA, a lot of DNA in your cheek cells, a lot of DNA in your cheek cells.
I know one of the patients asked on the comments regarding one of the videos that we posted regarding Prostox, was that is there any degree of, I would say, more precise information for blood versus saliva?
That's a great question, but no, the markers are exactly the same. So because we're testing your genetic material, your DNA, it's the same in every cell. The places we look, they don't change. So no matter what you do, we could test from any source, any blood, your tumor, your normal tissue. It's always going to be the same. It's your DNA. It doesn't change. Every cell has the same DNA in it.
What is the process from the time that you receive that cheek swab to the time of the reporting?
So we're committed to processing all samples within 3 to 5 business days. Right now, Prostox is run twice a week, Tuesday and Thursdays. So we wait for the samples to come in on, Tuesday, as late in the day as we can to collect them and run them all. The first step, we just extract the DNA from that swab, and we make sure it's pure and clean, which it always is. And then we separate it to test for 32 different spots in your DNA that we're looking at. We get the results of that, and then we put it into a statistical algorithm that actually comes up with 1 billion different combinations of those markers and puts you on a scale of risk. Thank God for automation, AI, and statistics, because that would be impossible just for a person to do. And with that, we come up with your score. And depending where you fall, you're either high risk or low risk. So that's all done relatively quickly through our algorithm. That's a statistical method. If a sample came in Tuesday at 4 o'clock and got on that run, we'd have results by 9 p.m. That's how efficient it can be.
When you're in the low risk situations and you're communicating that to patients,
Yes.
if that time frame's within that 5 to 7 business days, or is it as soon as that Thursday they're going to receive it that night?
They're uploaded, they're checked, and then we upload, and then the reports immediately go out from the system.
And then the high risk ones, they go to the doctor, and that takes a little more time because he does need to communicate that to the patient.
Yes.
Okay. In scenarios where, if you've never had a miss, which is fantastic, you're not having to rerun them like we have to do with PSAs and all of that. Right. You're not having these errant numbers. Do you hold on to that DNA for like future reports and different things? Like what is happening to those cheek swabs and that information? That's and it goes in a great bigger database, I'd imagine?
For people that join a study at MiraKind, that's part of being part of the study. We do ask to keep the DNA. Through the physician, that's a choice with the physician and the patient. Do you agree to future group research? So, we won't reach out individually to patients, but what we'll do, for example, right now we're doing a project where we're looking at all patients that got a high-risk result. And our question is, what did they do? What did the doctor recommend you do? What did the patient decide to do? And for patients that were treated where we have follow-up, what was the outcome? What was the chance? Did you get toxicity? Did you not? So if someone was high risk to Prostox and they said, I want SBRT no matter what, and they got it over the next year or two, what % of those patients did have toxicity? And we're seeing that is high, as we'd predict, versus those that got a slower course of radiation, what was their risk of toxicity? And as we would predict based on our signatures, it's very low. It's 10% or less. You follow up with the doctors, making sure that our low-risk patients were low risk, right? 85% of people are low risk. They'll get SBRT. We follow those patients. Did anyone in that group develop toxicity that you can't explain? And as the database grows, I'd expect that we will continue to update the signature. At this point, it's been the same from our first discovery, which was in 2018. We've had several additional data sets, but it really is the same set of markers that predict toxicity or side effects. So it has not changed. But as we expand to larger populations of people, it might adjust slightly.
Right now, we're talking about Prostox when it comes to prostate cancer. Another question we had from a channel is the patient not only had prostate cancer, but they had another tumor type. And so they were going, do you guys have something for this in lung or in any other areas? So would that same mutation be able to tell you predictive factors in other areas that you guys may go into in the future?
Absolutely, we believe so. What's interesting in radiation is obviously we treat all parts of the body, but side effects just may be different, right? So in the prostate, we think the late toxicity is due to fibrosis or scarring of the prostate. There are other parts of the body where that may not really bother you. I mean, it might not bother you. You have a lot of lung. If you have a spot that fibrosis in the lung, you may have no symptoms from that. But for example, in breast cancer, we see very similar fibrosis as a late toxicity. And we have been looking to see if the genetics are the same, and they do seem to be very similar. The genetics of late toxicity in one tissue type versus the other.
I mean, this can help in all types of cancer.
Yeah, absolutely.
Yeah, I mean, it's interesting talking about the scar tissue to the prostate, because I think that when people think about radiation, you kind of picture this laser beam that's going into the prostate, and it's like, eroding whatever tissue's there. But in reality, those cells are dying very slowly.
Right.
And so it's a much longer process than I think patients understand, which is why the PSA doesn't shoot down the way it does with surgery. And with that being the case, that scar tissue, I don't think we realize how sensitive the prostate is in regards to those types of things, because I think patients can go, what are you talking about? I got radiation like 18 months ago. Why would it matter now?
Right.
And the fact that your body's healing and now there's new things, it's an interesting predicament. And so it is exciting that we have technologies like this. When it comes to Prostox, I always love to, when I talk to people like you who create these amazing technologies, what excites you the most about it?
In the field of radiation, we've never actually known what the pathways are that lead to that toxicity that happens at 2 years, because we can't see it. But there's clearly something set off at the time of radiation that is some process that in a person that doesn't develop toxicity winds down, but with someone that does develop toxicity, there is some ongoing process. So I'm very excited about looking into kind of what these genetics, what happens, what is set off, what cascade goes on. I think that will be incredibly informative, with the potential, besides at this point saying, well, just don't get that treatment, get that one instead. When that's not an option in all cases, then there might be interventions. If we say, okay, this pathway is just stuck on, there's a medicine that shuts it off, there might be ways to prevent these things from happening. I am really excited that we're finally looking at how a patient predicts their outcome. We've been so focused on the tumors. There's so much it doesn't explain, and it makes so much sense that it's the patient, their response to what we do, that predicts outcome. I'm also very excited that microRNAs are being used in this way. I mean, people were all excited about them at first and try to look at them in cancer. And there's been a lot of work to try to give microRNA replacement therapy, but it turns out even a single microRNA, which is a tiny little thing, causes all types of side effects because they're so powerful. So it's really exciting to have an avenue to just say, no, we need to pay attention to, one, a patient's genetics, but this whole new understanding of genetics, because there's so many possible applications. It's just endless.
When we talk about prostate cancer, it's in the sense of, okay, it's a slow-growing disease. And for some men, obviously, it's not. But for the majority, it is to a certain extent. And then because of the treatments with hormone therapy being so effective in radiation, it's almost like a chronic disease. So from the time that you can be diagnosed in 2010, you could be benefiting from treatments in 2030 and 2040.
That's
and
amazing.
That new technology coming out, it's nice to have it in prostate cancer because you can be grandfathered into new technologies and treatments. And so hearing things like that, it's really exciting to know that there can be just new discoveries that are happening, not just in, like you said, turning off these types of patterns that are happening with cancer, but I think also looking at what can happen as far as future assays and what it can tell you when it comes to these things. If you were a caregiver and you're trying to talk your husband or partner into getting this, what would be that discussion point? Because there's so many caregivers who watch this channel and, they hear about something exciting, and then I get the feedback of, yeah, I tried to talk my husband into getting it, and he said the doctor didn't talk about it, so I'm not going to get it.
I think it is understandable that, and I've seen it many, many times, that patients, they believe if they do exactly what the doctor says, that they will fare better. But I will say, doctor, we are only human. And, we cannot keep up, on everything. I have appreciated in the prostate cancer world how educated prostate cancer patients are. And I think they have a little bit of time, which is great. So it's not a panic, I need to sort this out yesterday. I'm sure there's some sense of that, but I know a big message is just hold on, learn because you have time. It's wonderful that they're such self-advocates. It's just not the case for all cancers. I would say to the caregiver, it's just one piece of information. All of this is, you're just collecting information. People spend more time buying a car than they do making decisions about their cancer treatment.
That's so true.
And interventions that could affect them forever, not just their cure, but their quality of life. And I'm such a believer in patients need to advocate for themselves and educate themselves. I mean, that's really what MiraKind's about, actually. It's all about education, access, like empowerment. Like, I want patients to know you're a big part of these decisions and you are allowed to gather information. You should. And if you have a doctor that isn't comfortable with you getting a second opinion or educating yourself, I will say that's a red flag. I encourage my patients always, and if people are worried about it, I'm like, you never should be worried about getting a second opinion. Like, absolutely. Or collecting more information. And if you bring me something that I haven't heard of, I appreciate you educating me. Let's look at it together. Let's take this time. Let's read about the literature supporting it, and let's just analyze that together.
Oh, you're talking to the right audience for sure here at PCRI. We are big believers with you. So let's just talk about access for a moment.
Sure.
You mentioned that with MiraKind, they can go through the foundation and they can get it for pretty low cost. Now, I like to drill down just to pricing for patients because I think when I would think about a really cool technology like that, I'm like, oh, it's probably like $3,000, $4,000. You know, it's like it's such a cool technology. You got to pay for these things. Yeah. How much is it really through MiraKind to get it?
At this point, it's $500 through MiraKind for one of the two tests. If you're like, I'm getting SBRT, I just want that one. Or if you want both, it's $900 discounted.
That's really accessible for a lot of
That's
patients.
The goal. That's definitely the goal. And as we go through insurance, the price of these technologies is clearly more than that. But our goal is to have patient costs be capped at $395, which again, I'm hopeful, I'm a huge believer in patients, and I'm just hopeful that as a business person, which I'm not, I prove you can do the right thing and still survive.
Yes, well, we appreciate it nowadays. So let's talk about different states. Can anybody from any state get Prostox?
Perfect. We are licensed in every state. We are in the final process with New York. So at this point, we're not allowed to accept samples from New York. We have some research colleagues that we do research from patients on New York, and we're allowed to access their samples. Hopefully we're very close on that. We've already had the inspection with the lab, and we're going through the final, I think, dotting our I's and crossing our T's. So that will be great so that we can really test everybody.
I always feel like it's New York and California. I always hear everything's covered except in New York and California.
Exactly.
We're still figuring it out.
Right, exactly.
So, okay, that makes sense. What about international?
We have some international collaborations. We do have patients that order through MiraKind internationally. We're setting up studies with a few places. We have a cohort in New Zealand and a group in Australia, and then some collaborations in England and Ireland that we're doing. But patients can apply from wherever, actually. I like to let them have access to mailings a little bit more. They pay for a little extra mailing because they make it hard to send things internationally.
That makes sense. So we have patients, 50% of the YouTube audience is international, which is why I asked.
Oh,
so,
fantastic.
If I have a patient in the UK, like I'm a patient in the UK, I call. Am I calling your company, MiraDX?
You should go through MiraKind, actually, because we do allow that. I appreciate those thoughts because we're thinking about as we go for insurance in the U.S., but MiraKind may be that access for international patients ongoing.
Yeah, we have a lot of people who have had interest in Canada, UK, like all sorts of places, Germany. And so I think, it's a huge interest, especially since we do see radiation in different countries kind of coming up as well in not just the US, but the technologies that we see in the practices. So that's also exciting from an international perspective. Now, when it comes to MiraKind, it's a completely separate nonprofit than the company MiraDX, correct?
Yes.
Okay, gotcha. It's amazing that you created that. That access point.
I went to this one-year business program after I'd started a company and realizing I had no business experience, hadn't even taken an economics class. I was all science. And I started this company with the goal of getting important information to patients, which I thought would be super easy. I was like, all right, I'll be a doctor specializing in oncology. I'll do research. Someday, if I am lucky enough to find something meaningful, it'll be so easy to get it to patients. but actually it's so hard to get things to patients. I was stumped. I'm like, I can't believe how hard this is. I don't understand. So I took a leave and went to business school, did a one-year program. During that time, I was like, wow, okay, companies in the medical space are not always really about patients, which I was all about patients. It was at that point I spun out MiraKind. I didn't really spin it out. I created MiraKind because no matter what, I wanted patients to be able to get information that was useful to them. As a doctor, I still practice and see patients. I learned so much from my patients. I mean, they're an incredible source of knowledge. Everything about them. Like with our first marker, literally I can meet a patient and I know if she has the marker or not. I can tell with all I know about the marker and knowing those patients. I can't tell who's going to have toxicity. So the nonprofit really stemmed from my love of patients, my understanding of the importance of patients and how much I could learn from them, and the desire to make that the driving force behind everything we did.
That's so cool. I love it. So you're still seeing patients. Are you treating breast cancer patients, prostate patients?
I treat breast cancer, actually.
Awesome. And you do it at UCLA?
Yes.
Okay. So breast cancer patients can come see you. We Google your name on the UCLA website, and that's how we would see you.
Yep.
Okay. So how many patients have had Prostox?
We are at about 3,500 at this point.
When it comes to stressors, though, I think that this is another kind of big picture question. There's so much guilt associated with sometimes getting cancer.
I know.
I just feel for these men because they feel like there's something they could have done differently if they hadn't, eaten a certain way, drank a certain way, gotten to that fist fight at the bar, whatever it may be.
Yeah.
There's always these factors of things that patients kind of go, did I cause this?
Right.
So when we talk about the stressors and the research that you've done when it comes to stressors in DNA and cancer, is there anything that you would tell patients that would maybe give them a sense of relief for it, that they don't have this responsibility?
These differences that we're seeing that people have in their DNA explain the genetic risk of cancer much more. So honestly, your number one risk of cancer is having cancer in your family. You can be the healthiest person in the world, but if your wiring is such, there might just be normal events that mean you're going to have cancer. I mean, our first marker actually in KRAS, it's a risk more for women of developing cancer. It turns out that estrogen, menopause, puts them at higher cancer risk. They should have stayed on estrogen, which was unfortunately, hopefully, is becoming the norm, but was a problem because of some studies in the past. But so things that people normally experience, if your DNA is different in a way, you're just living your normal life and you didn't do anything wrong. You're just living, and that puts you at that risk. I think as we understand more about that risk, we might be able to personalize prevention. As I said, it is a tricky thing, honestly, because no one wants to know if they're at cancer risk. Even if every person in your entire family had cancer, I have never had a patient that knew they were going to get cancer, because there is a lot of guilt. It's important that we try to better understand, because then there could be personalized prevention, but we don't have the information, and that's not a patient's fault. That's just the world's fault. It's complicated to understand. The business world isn't supportive of that. Insurance doesn't want people to be worried to stay on if they're at high risk of cancer. So in the business world, it will never be a model because insurance will never pay for it. That's some of the work we do at the nonprofit, is try to understand that. Only helps if you can figure out what the intervention is to help avoid it. Otherwise, it's just bad news. So
that
it's
makes
tricky.
sense. And even we've talked to a lot of doctors, and they themselves are like, I don't really want to get BRCA testing. I don't really want to know. Like, this is a lot of information. I don't know what to do with it.
Right.
But from your perspective, do you encourage your patients in prostate and in breast to get BRCA testing?
I do, actually, at this point, because there's finally targeted medicines for BRCA mutant patients, and you could prevent for breast cancer patients. There really is an option to avoid ovarian cancer. So if I really think someone may have BRCA, which is really pretty rare in breast, honestly, we test many patients for BRCA. I've never been surprised. Like, it's pretty obvious generally who's going to have it. Someone young with a lot of cancer in the family, and that's fine, because I do think because there is therapeutic different medical interventions if you have BRCA, besides some prevention for the ovaries, I do encourage my patients to get it. I don't know enough about the prostate cancer patients and the use of some of these BRCA-targeted medicines in prostate cancer, but I'd imagine they're certainly being tested. If they're not being offered, then it's useful.
You had mentioned now you're looking at an assay in regards to immunotherapies and prostate.
Yes.
Is this something you can speak to publicly, and what
Sure.
type of technology is that? What can we look for? Because we have been talking about immunotherapies and prostate that we're taking from other types of cancer that aren't even approved, but we're getting compassionate care use where the patient's getting it for free, and we're really excited about it.
Yes.
So what type of developments have you guys seen?
Actually, when I came to UCLA, the first test we developed was predicting side effects to immune therapy, and we call it Prostox. That developed through a collaboration with Tony Rebus, who's a great medical oncologist who treats melanoma, who'd run many of those early immune therapy trials. And when I first came to UCLA, I met with him because he's friends with Mike Steinberg in the department, and I was describing how I was hoping to use this new understanding of genetics to identify patients who would have side effects from radiation. And he was like, you should test this in immune therapy. I have this problem. 25% of my patients have these weird autoimmune things. I don't know who they are. They all look the same. It's clearly something about the patient. And I would say immune therapy, we've been very aware and worry about toxicity for radiation from the beginning of time. In medical oncology, before immune therapy, it was rare. There'd be nausea, there'd be GI upset, they'd have medicine for that. These new immune toxicities that they get, immune-related adverse events are called, they were much more like what we see in radiation. And they're really problematic, right? They can be terrible, they can be life-ending, they certainly can be life-altering, and they're lifelong. So the first test we developed with this new genetics, besides our first marker, was predicting immune-related adverse events. That first version of the test was really developed in these very advanced melanoma patients. We did test it in other cancers. It seemed to predict as well. But I knew that we should test kind of the people that are getting that drug now, which tend to be people with really limited disease. It might be the first medicine they're getting, just a different population of patients, much younger, healthier, different people than our first group. So we actually just completed a really large validation study, and we have a great signature that predicts a group of patients that get toxicity very quickly within 1 to 2 cycles, and those that if they're on it for a year, they'll get it. We're just getting ready to partner with different groups around the country on that test to really say, how is this useful? How would you manage patients? And actually, we have been using that test with Dr. Schultz for many years because he understood how to use it. There were choices, and if someone's going to have immune-related adverse events, he would take the other choice. So in that setting, it was very clear. It's a little less clear if it's hugely, this is your only choice and it will improve survival. So what are we going to do? I mean, if you're at high risk of toxicity, and we need to work with the clinicians treating those patients to really understand how that information will be most useful. But yes, so I think that's also a great test. And we're, getting it all validated in the lab, actually. So within the next month or so, it's hot off the press.
Wow. Would it be available through MiraKind?
Yes. My current plan is every test before we get insurance approval, we will always have 2 paths in. So it'll be physicians who, with no charge, who are helping us figure out the best way to use it for their patients and making sure it's useful to them, and then MiraKind. And, there might be some things that physicians are just like, I'm just never going to use it, but patients want, and those may forever live just in MiraKind. I'm always hoping for the two-path approach and deciding, when things move from mainly MiraKind or equal both places to this is insurance, we're going to encourage doctors to use it, but still always make it available.
A big thank you to Dr. Joanne Wiedhaas for being here today and giving us all this information. I would also like to say a big thank you to Dr. Michael Steinberg, who's the vice president of our board here at PCRI. He has been instrumental in introducing us to physicians like this who are changing the world of prostate cancer and bringing new technologies. And to Dr. MiraKind, because he's going to be speaking in September here in 2025, and we're very excited. But the data that he provided with the clinical trials to even get Prostox to market is incredible. And so we're very grateful to him as well. And you could also see his talk on our channel on SBRT here, and I will link it in the comment section below. I'll also link our helpline for those who need help with their case and just more information about your specific prostate cancer case. The helpline can also answer questions that you may have on Prostox. And if you do have questions that you would like me to ask future experts, please leave them in the comment section. It is just a great way for us to create future content. Now, if you are facing radiation, please watch our radiation videos. I'll go ahead and link a playlist as well in the comment section because I just want you to know what your your options are. It's always good to put your quality of life equal to your treatment choice, and to make sure that you're knowing what your options are when it comes to side effects and what you can do to mitigate those things. We want to make sure that you're thinking about yourself as a whole person, because you're worthy of that. We want you to know how important you are, how much we care, and if you need help, PCRI is here. Please remember, most of all, you're not alone, and I hope you have a great week.